Good morning, everyone. I just wanted to welcome everyone to our 5th day of the Bloodless Medicine and Surgery and Maternal Health Program. So far, it's been a really exciting week, and we've gained a lot of information from some excellent speakers. We're going to start our day off this morning with our keynote speaker, Dr. Spiess. Dr. Spiess is presently an Emeritus Professor of Anesthesiology at the University of Florida School of Medicine in Gainesville, Florida. He was born to academic parents and grew up steeped in a research background, with his father being a geneticist and his mother a biochemist. Dr. Spiess attended Denison University in Gainesville, Ohio, and they just bestowed upon him in 2017 the highest honor, the Alumni Citation for his research work in medicine. He attended Rush Medical College in Chicago, followed by the Mayo Clinic for anesthesiology training, where he specialized in cardiothoracic anesthesiology and was chief resident. He returned to Rush for his first faculty position from 1983 to 1990. From there, he traveled to Seattle, Washington to become the chief of cardiothoracic anesthesiology at the University of Washington. Spiess left Washington State when a business opportunity for his new wife became available in Richmond, Virginia. He took the position of vice chairman of anesthesiology at Virginia Commonwealth University in Richmond, where he stayed for 17 years until pursuing his last position as associate chief for anesthesiology at the University of Florida. Dr. Spiess has focused his research upon blood, its critical oxygen carrying capacity, oxygen therapeutic pharmaceutical development, previously known as blood substitutes, risks of blood transfusion, and coagulation of coagulopathies, and development of monitoring technologies. His extensive work in blood transfusion risk has led him to be an outspoken proponent of patient blood management. He has authored over 200 peer-reviewed academic articles, more than 40 book chapters, 7 textbooks, and appeared on the Discovery Channel and in many other lay media. His work has been funded mostly by the U.S. Department of Defense, and he has led major conferences for the DoD, the NIH, the FDA with regards to critical blood issues. As it pertains to patient blood management, Dr. Spiess has spoken at SABM a number of times on every continent except Antarctica, where blood management is not a great issue. He has worked with government agencies, Australia in particular, to enhance the support for liberal thinking on blood management. His present work at University of Florida has a major focus on trying to get the very large medical center to become a showplace for anemia correction, as well as a world center for bloodless medicine. Dr. Spiess is particularly proud of his involvement with the Special Forces, the United States military, and his efforts to help the government agencies understand the issues when it comes to when blood is not an option. Dr. Spiess has won several awards, including the Award of Excellence for the Bloodless Medicine and Surgery Society in 2019 for his excellent contributions to the science and practice of bloodless medicine and surgery. So as we can see, we have an amazing keynote speaker here this morning, and I am proud to introduce Dr. Bruce Spiess, Bloodless Care, the safer, cheaper, and more effective option. Let's welcome Dr. Bruce Spiess.
Good morning, and thank you, Kelly. It's really a great honor to be here. I'm trying to get my share screen up. There we go. I've changed the title just a little bit this morning because when you gave me this challenge to speak on the subject, I did a lot of thinking about it, and really the challenge that Nathaniel gave me has helped me to gel an awful lot of my thinking. So you're going to find me pushing the edge of the envelope, and I tend to do that quite a bit. I think I'm known for thinking outside the box and pushing people to really think. But there's an evolution going on in patient blood management, and that's very helpful and useful. But I think the evolution is going to lead us to a point at which bloodless medicine is the default. In other words, bloodless medicine is the final stage of evolution of patient blood management. And I'll get to that as I work my way through it and show you how I've arrived at this. I'm not sure many of us have arrived at this thinking yet. You all have who are on this, perhaps all of you have who are on this wonderful call, but I'm not sure the rest of the world has come to this, and they certainly seem to fight it and kick it as they go towards embracing it. Kelly was nice enough to say that I'm an emeritus professor. Oh, come on, let's see if this will advance. Doesn't want to advance. There we go. So you'll now notice that instead of living in Florida, maybe you won't notice it, but I can tell you that it is now 5 a.m. my time in the West Coast of the United States. And I've just moved and retired from clinical medicine to what my wife will tell you is not really retirement, but now I have lots of time on my own. Instead of having to be called to the operating rooms all the time, I have time to think and to write and to do a lot more, I think, to influence the world. So I now live on the far west coast of the United States in Palm Springs, California. It's a beautiful place. That view of the mountain is right behind my house, Mount San Jacinto, and that desert sunrise, I actually took that picture a few weeks ago myself out of the back door of the house. So, you know, I now live in a very beautiful place, but unfortunately a long ways away from where many of you are attending today. So I have some disclosures. As you can see, most or many of them have had to do with transfusion and companies and such that deal with transfusion, as well as artificial blood companies. None of them, I think, will have influence on this particular talk. And I'm going to give you the conclusion and use that as an outline for my talk. And the conclusion is that blood is a complex organ system. It is perhaps our ultimate organ because everything in blood touches every other organ in the body at least once a minute if you have normal circulation. And I think that single concept is the entire misunderstanding of where we've come to today, which is that medicine doesn't really teach about blood as an organ or as an organ system. They teach little snippets and little bits and little pieces And we focus an awful lot on hemoglobin and oxygen carrying capacity, but we don't talk about the complex interactions. And to me, the beauty of what I like to embrace in medicine and what I see as God's work in medicine is biologic complexity. And so the more and more we teach about the biologic complexity, I think the more we'll understand blood as a complex organ system. And I'll put it to you that we do not transplant organs until they've completely failed. Nowhere do we transplant a liver transplant or a heart transplant until that organ has failed. We can't go to the refrigerator and just grab a little bit of liver to throw it in when somebody's liver enzymes are elevated, and on it goes. So we're in a situation, I think, where medicine's teaching has had profound misunderstanding of blood as an organ. For over 100 years, I think medicine has had it wrong, and we have really misled ourselves in terms of both the philosophy of where we ought to be going and ultimately using transfusion as a crutch rather than as a full understanding of the organ. So the concept of bloodless medicine, I think, eventually, and it's going to be years and years and years of hard-fought teaching by a number of us, many of you on this phone call, that the concept of bloodless medicine has to become the default position for all of medicine. We're a long ways from there, as you know, but I think that's where it has to go. The World Health Organization has put this wonderful call to action through Axel Hoffman and other people who some of whom are on this call, who've been involved and have been pressed forward, and it calls for all 192 member countries to endorse and institute patient blood management. That just came out in October 2021. If anybody hasn't read it yet, if you haven't sort of mentally endorsed it yourself, please do. I think it's one of the finest articles I've ever read because it's a profound summary. It's compelling, and it flows beautifully as well. And you can just plain read it without having to have profound knowledge in our specialty. It's meant to appeal to governments and to be a briefing paper. It talks about requiring multidisciplinary patient quality focus. And that's where we've evolved to now. Whereas, and I'll go through a timeline for you in terms of development of patient blood management, but we're now finally focused on the patient as the center of our universe. Isn't it amazing that in medicine we had to get to this point? That we had to, after 120 years, actually finally get to the point and saying, well, it's the patient that really counts. And what would you do for yourself? So patient blood management has evolved from really the AIDS crisis in the 1970s and 80s, and I'll say it from those 1970s, because it was really the 1960s and 70s that was the hepatitis crisis, which led to the AIDS crisis. And that led to understanding transfusion safety, or a focus on transfusion safety, and eventually blood reduction and blood salvage, and then whole healthcare total patient focused on quality. And that's where we are now. But there's still a lot of fighting and pushing back and saying, well, it's too hard to do that. What do you mean it's too hard to focus on a patient? Really? What would I want for myself? So patient blood management is an evolutionary stop. It's an evolutionary branch on this branching tree that will eventually become bloodless medicine, which is where we have to be in the future. So has patient blood management matured? Absolutely, it has not matured. It's in some ways in its own infancy, and that certainly the number of centers in the United States who are getting on board is increasing, but it's by no means even established itself as the default position for centers in the United States. And when you think about it, the patient blood management, which is still focused on ways to reduce transfusion by treating anemia and stuff, it's still fundamentally different than bloodless medicine. So patient blood management in and of itself still assumes that transfusion is a default position, or that it is something that we can try to limit, and it merely fights back to say, let's not get there. Let's not get to a trigger. But it doesn't say that the very concept of a trigger to begin with is a non-starter, is an incorrect concept to begin with. So we've got a long ways to go. So I love this slide, and I'll ask you what you see. And what you see is not always the truth. Obviously, in my country right now, we have a lot in politics about what you hear is not always the truth. But how many of you see horses? How many of you see zebras? There's not a horse in this picture. These are all zebras. And if you look at it, the horses are just the shadows. So squint at it, look at it carefully, and then think about it. Think about what we've done with hemoglobin. Think about what we've done with transfusion. Do we really understand the biologic complexity of how oxygen is delivered? Or have we just simply seen the obvious thing? The bright red that's in front of our faces all the time, the bright red that is the shiny object that is so easy for us, maybe 100 years ago, to ascribe all kinds of different things to. But when it comes to really in-depth knowledge, we have not, as medicine yet, embraced that. And as a physician who does an awful lot of research, specifically in this area, I think it behooves us as physicians to embrace the complexity and to say, well, now, wait a minute, maybe I really don't understand everything, and maybe I'm just seeing the shadows and not the absolute truth. So transfusion, and you can make this timeline more and more and more complex, and people can put many more things on here. But, the first transfusion in 1667, and shortly thereafter, the outline of transfusion by the Pope, was the start of all this hundreds of years ago. But it goes all the way back into Western civilization with a fascination with blood and the Romans and stuff. But really, the modern transfusion world begins about either in 1818 or 1900, depending on which one you want to take. And of course, it gets exploded by the possibility that we can take this substance, blood, and we can put it in a refrigerator. And for all intents and purposes, in the early 1900s, it looked the same when it came out of the refrigerator as when it went in. Okay, so it's a little darker. It's got a little less oxyhemoglobin. But then, of course, in the World Wars and the Spanish Civil War, it really exploded in its utilization. But what really exploded was not just utilization of red blood cells, but it was the utilization of plasma as a volume expander that saved so many lives. And what was, in terms of transfusion, was soldier to soldier and whole blood. But I find fascinating, and I've had talks with the people who first described ARDS, that it was in Vietnam, in the Vietnam War, when the United States was involved with Vietnam, that really large-scale banked component blood, in terms of red cells, was first utilized on a major scale. And is it any wonder that at that point is when the first descriptions of ARDS came out in shock? Was there ARDS in World War I and World War II? Yeah, probably, but with shock lung and stuff. But I've asked the people who were there on the front lines, and they said maybe it really was trolley. Maybe that was ARDS manifesting as trolley. But it goes on and on and on. There are signals that we in medicine have preferred to put our blinders on and not see the zebras, but see only the horses walking by as shadows. Hepatitis, for example, around the world has been a huge problem with transfusion, as have been many, many other infectious diseases, and still are today. But hepatitis was first described in transfusion in 1947. That's interesting. That was the same year that the call came for everybody to be transfused at 10%, at 10 grams per deciliter or 100 grams per liter. That was the exact same year that we first proposed a trigger that was based on nothing. And that trigger, that 10 grams per deciliter, continued until the AIDS crisis. Nobody ever asked, with 10% risk of hepatitis conversion in the United States over that time from 1947 until 1987, 1988, 40 years, nobody ever once asked, is the trigger right? Or does the trigger really signal anything? Is the trigger for transfusion just a useless number that, because we trying to be so simplistic, we're going to hang our hat on a number and, oh, it just happens to be a round number that a village idiot can remember. So and now we live in a world where we've changed the trigger, and we think we're pretty cool because we've reduced the trigger. But the arguments can continue today. Is 7 to 8 grams the right trigger? Is 6 grams the right trigger? What's the right trigger? I'm one of the few people in the world that said there shouldn't be a trigger. The trigger of using hemoglobin is a false god. It's the horse. We need to understand the zebras walking through the world. But now we've gone from the HIV crisis to cost containment, transfusion reduction in a profound effort to try to reduce utilization of blood that and we've done a great deal to increase the safety in terms of transfusing mostly HIV, but also a few viruses. And I'm going to say that a very few viruses, because we only test for a few viruses compared to the numbers of millions of viruses that are in there. And now, just now, we're starting to talk about, well, maybe we should treat anemia. What a unique concept. Maybe we should treat anemia. How long along that continuum did it take us to get to this point? But nobody's yet talking about, do we really understand what we're doing with blood? And can we give a unit and not hurt somebody? Or maybe giving a unit isn't such a great idea to begin with. I stole this slide from a presentation that we just gave the other day, which is, and many of us are talking about it, is PBM is in the midst of a cultural shift from a transfusion blood component focused effort to a patient blood management focused, patient-centered team sport. Team sports are much more difficult than tennis or swimming, where the only thing you have to depend on is yourself. If you have to depend on 5 or 10 other people all working together to focus on a patient, there's an awful lot of communication. And communication in some of our complex medical centers isn't the best, and it's difficult. So there's no data in support of transfusion making a large difference in outcome in mankind. And there are now, there are very few references that speak to the positiveness of giving a transfusion. And there's extensive data, of course, in retrospective databases demonstrating association between transfusion and adverse outcomes. But yet we still worship it as a trigger point, and now all we do is argue about what's the right trigger. Well, that to me philosophically is, again, the horses and zebras. What are you tilting at? What kind of windmill does Don Quixote chasing after that isn't actually real to begin with? There are now 68 randomized trials of liberal transfusion versus less liberal transfusion. Yeah, and the transfusion triggers between those are small. But how many lectures have I attended? How many meetings have I attended where somebody says, well, you really can't do a transfusion versus no transfusion study? Of course you can. All you have to do is have the fortitude to understand and put forward a randomized controlled trial of, pick whatever transfusion trigger you want. I don't care. But then do it against the finest of patient blood management. We could actually do that. And I swear to you that if you did that, you would find out that actually bloodless medicine, or using all the techniques we have to never get to that transfusion, has a better outcome. I believe, but nobody's done it yet. Instead, we continue to do these randomized controlled trials. And I, in the last few days, have heard that another one's coming. Trick 4, okay? Trick 4 is a Canadian study to look at outcome after heart surgery. If you focus on just the right patients, can we find that transfusion might make a difference? Well, in 68 trials, transfusion didn't make a difference. Why are we still looking for just that one more study that might justify how we've done it wrong all this time? Is that insanity? This is what Einstein said. The definition of human insanity is doing the same thing over and over again in hopes of finding something different. Wow. But we're doing it because we have this deep-seated belief that somewhere transfusion is good. If we could only find that, if we could only find, and if we could only turn over that one rock where the piece of information is hiding underneath that says, you did it right for 120 years. It doesn't exist. We need to understand biologic complexity and dig into it and realize that any trigger is not the right trigger, and that we're tilting at windmills and going after things the wrong way. I will dive down a rabbit hole and go off script for just a second, but I showed you that beautiful sunrise at the beginning from Palm Springs, California. Well, Palm Springs has this monstrous mountain right behind me, and come to find out that Einstein spent a fair amount of time here in Palm Springs, and he would climb that mountain. He would climb to about 2,000 feet, sit on one of the rocks, which happens to be on one of the trails I like to hike out here, and he would watch the sunrise, because he had a clear view of the Earth's surface and he could see the light emanating from the sun. And from that, he got inspiration for some of his theorems on light and energy and mass and stuff. It isn't where he wrote E equals MC squared, but it's where he came up with a number of his thoughts. It is to me very inspiring to go to that spot and say, wow, Einstein sat here and watched the sunrise. So oxygen delivery is oxygen delivery basically dependent upon hemoglobin concentration? Of course it isn't. And I've given lectures to all of us on this. There are some monstrous assumptions we've made over the 120 years of this. Oxygen delivery is not dependent on hemoglobin concentration. More hemoglobin is good. That's another assumption. More hemoglobin is not necessarily good. And the number one assumption is that transfusion improves outcome. How many times have we proven that false? And bank blood is equivalent or a useful surrogate. Well, now we know it isn't. And replacement of lost blood is the right thing to do. And we've argued over these triggers. What are the next big assumptions? What are the next big things we'll come up with? What is it if we all assume? There's a risk if the assumption is wrong, and medicine has made these assumptions forever. And that's what the assumption means, is it makes an ass out of you and me if you assume and you are wrong. And rather than continue the dogma of just trying to prove that the assumptions that we've made for 120 years are right, why can't medicine go back to the very beginning? And so this is one of my favorite papers by Aurier, and Aurier's written a number of good things. But is it really dangerous, anemia or transfusion? So now we're focused on the anemia. Let's get rid of the anemia. But the focus on this is a nice medical discussion of statistics and looking at the data. But the philosophy of, are we making the right assumptions? Or we shouldn't be making any assumptions, but have we done the right research and looked at the data from the right angle, is still not there. Aurier has taken a huge effort in trying to pull people to look at the data correctly. That PBM is not the end of the evolution. PBM is just a stop on the way, perhaps, to a full-on change in our thinking. And I think the people who are listening today are some of those who are capable of forcing that change. And I think number one is a complete understanding of blood as an organ. I'm going to show you how complex and beautiful I think blood is. And why is it only people like me who spend their entire life studying this get to this understanding? It's because we don't teach it in medical school. We give one or two lectures about hemoglobin. We give one or two lectures about various cell types. We give almost no lectures about coagulation other than showing the same pedantic, stupid protein cascades over and over again. And there's not a single medical center in the world I know of that either talks about the transfusion decision and when and oxygen transport to the depth that physicians need to know to make the right decisions. So transfusion does affect outcome after surgery. Less is more. We know that, and we know that immunosuppression is huge. When is it that there's up to a 7-fold increase in adverse outcome by giving a therapy, yet everybody continues to want to study why that therapy is just so right and so perfect? We know lots about pulmonary dysfunction, and on it goes. I'm going to move past that. So why do we just continue to follow those lemmings off the cliff? What if medicine with blood transfusion had it wrong right from the very beginning? What if the basic premise itself was basically flawed? I think it is, and there's few of us who've been willing to stand up and say that. We've all been nice to go and look at the data, as Ari Shander has, and try to convince each other. But it takes a heck of a lot to look in the mirror and say, I had this wrong from the beginning, and I need basically to start over. And the start over is for all of us in medical school to embrace and teach that blood is an organ. We should have as much time in a course series as does biochemistry or other physiology, and really take a deep dive into how much this makes a difference. When the number one therapy in Western medicine in the United States is a therapy that doesn't work, then we're somehow teaching people the wrong thing. Blood is a complex moving fluid. It has over 2,700 different proteins that we know of today, multiple different cell lines. They all interact, and the interaction of how they relate to each other in normal physiology and disease is beautiful. And we need to teach that. Blood touches and it regulates every other organ system. And so we can break down some of those silos. We can do some teaching, and we need to affect it and understand it, that blood is an entire ecosystem. And unless you understand how each part of the ecosystem feeds back into the entire ecosystem, you cannot maintain a healthy ecosystem. So blood and the vascular system are an organ. They are mature and they're balanced ecosystems. Now, here's the problem. Once an ecosystem gets unbalanced with challenge and perturbations, you can't just give part of the ecosystem back, especially a dysfunctional part of the ecosystem back, and expect everything to be normal. So once the ecosystem is dramatically disturbed, it's hard to restore homeostasis. And that's where we should study, is thinking about this, the forest through the trees, and how do you restore the forest when there's been a forest fire or something else. Single interventions cannot bring things to normality. You have to be able to understand the ecosystem and look at micro and macro interactions, and do not oversimplify. Can we have a transfusion trigger? How much profound oversimplification is that? And it is dead wrong right from the beginning. So, just if you, again, stand back and you take a look at it, we focus on blood and its oxygen carrying capacity, because that's obvious, right? There's millions of RBCs. There's so much hemoglobin in each RBC, but how many of us really understand how that actually works? Same with albumin. Albumin is a fascinating protein. Look at all the things it does over on the right-hand side. You know, when I go into the operating room, the only thing that anesthesiologists and the surgeons and perfusion and stuff want to talk about is, you know, is water flow between the vascular system and the extravascular system based on how much albumin. That is so minor compared to all these other functions that albumin has. And the biggest thing that albumin probably does is that it's the most profound antioxidant. So what does that have to do with how well red blood cells function? Well, the redox state of the blood, how many free electrons there are bouncing around, actually has a great deal to do with whether red cells are flexible, they're not flexible, they're band 3 protein, which sits on their surfaces and tells whether the cells are senescent and they need to be scrubbed from the circulation. So the environment that the red cell flows in and how many free electrons are available, how much oxidative stress there is, determines how well the red cell interacts with the endothelial cell. And here's this guy, albumin, who happens to be the best buffer that we have. How many physicians understand that and really can embrace it and really say, you know, if we get the things right, maybe we can have a different view that we shouldn't just waste this precious fluid and throw it on the ground. How about taking the idea that when we do surgery and we have lap sponges or we have Ratex or other ways of soaking up the blood, most of that gets thrown in the trash. Why is it that nobody has yet invented an automated, proper washing machine to extract that blood and get it back and get it into the patient? It's because we just think this is a wasted fluid and we can throw it away. So the complexity, and I'm already beginning to get towards over my time, but you can see that there's complexity and complexity, just the flow shear stress, the physics of the cells themselves. Why don't we teach that? We don't. We just say, you know, here's your one lecture on hemoglobin, and oh, by the way, when you get to the ward, some gray-haired old man will tell you when to give a unit of blood. That's absolutely just wrong. And I've spoken to you before that I think red blood cells have evolved in mammals to regulate tissue oxygen levels, not that more red blood cells increases oxygen delivery, because it doesn't. Because what happens is that we have a vast excess of red blood cells for the just-in-time FedEx or DHL or UPS or whoever is delivering in your neighborhood, just-in-time delivery. And the normal level of hemoglobin and hematocrit exceeds the need for critical oxygen supply by at least 5-fold. So you can, you know, the old time excuse, the horses versus the zebras discussion is always, well, you know, we evolved that way in case the saber-toothed tiger bites your butt. Well, no, we didn't evolve that way because of that. We evolved that hemoglobin and the amount of hemoglobin we have as an evolutionary advantage has something to do with an evolutionary advantage other than just giving more oxygen to the tissues. More oxygen to the tissues kills the tissue. My tissue wants exactly the same amount of oxygen all the time. And if you increase the amount of oxygen 5-fold to my tissues die. Oxygen is a profound toxin, and the red cells are there to regulate it and to normalize it, but not to provide extra. So the normal hemoglobin and hematocrit, I think, has evolved as a regulation of vascular tone, shear stress, nitric oxide flux, and signaling, profound, fascinating signaling to endothelial cells. Did you know that RBCs are important to coagulation? Here's all the effect that RBCs have upon coagulation. Why don't we teach that in medical school? It's because nobody cares to have the focus upon it. And here's some of the interactions with endothelial cells. We need to teach it. Coagulation is inflammation. We are now learning that in COVID, that coagulation is inflammation, and the two go backwards and forwards profoundly. And inflammation is complex, and coagulation is the first step towards inflammation. And platelets are the gatekeepers for both inflammation and coagulation. And we're back at the level of talking about chickens and eggs. We're back even in the COVID world, we're all focused on, well, these are platelets that are causing these reactions, and gee, this is a pulmonary disease, and the disease goes on and is killing us rampantly because we're not willing to embrace the biocomplexity that we should be embracing. And there are over 850 forward activating and backward controlling reactions in coagulation. You need a computer-based model to be able to even begin to understand it. But yet we teach the same pedantic little coagulation cascade that was worked out in 1957s. Wow, just so more and more things about red cells and why we haven't got it correct yet. So, in the AIDS crisis, we came out and realized that your own blood in the operation is your best blood. And so that's good. But how about if we didn't waste your blood to begin with? How about if we said that bloodless medicine, in other words, not ever having a dependency on some external source is the number one thing that needs to happen. I'm going to go past these vascular tree things because I'm going to get bogged down. But there's a standard coagulation cascade, maybe more complex than usually what we teach. But what we don't teach is all these other layers and layers and layers of complexity. Okay, can every physician understand all the depth that I'm talking about? No, but we need to go far beyond how we've taught it in the past. And we absolutely have to teach that transfusion does not increase oxygen delivery. As a matter of fact, in all the studies that have ever been done, there are at least 10 to 1, or maybe 20 to 1, if you just weigh the amount of paper, that show that oxygen delivery by transfusion either does nothing or decreases oxygen delivery to tissues. There's only 1 or 2 that have had a hint that maybe it somehow increases oxygen delivery. Yet we continue to try to find those studies to justify our belief system. And there's a very famous quote, and I'm going to get it wrong. It says something like, when your beliefs are questioned, everybody gets to work trying to prove their beliefs. And that's, I think, where we've come to if we've looked at the system as a whole, rather than just getting down and embracing the beauty and the complexity. Here's 2,3-DPG. Why is it that most physicians can neither understand 2,3-DPG, where it comes from, where it goes to, or how it's affected when we put blood into a bag and put it in a refrigerator? It has to do with oxidative stress, and it has to do with glutathione, and it has to do with albumin, and it has to do with all these complexities. It's not just so simple as you put it in a refrigerator and you pull it out the way we did 100 years ago, and things are just fine. Isn't it amazing that Jehovah's Witnesses actually do better, or at least as well, until you get them to the point of critical hemoglobin delivery, which is at about 3 to 5 grams per deciliter. Isn't it amazing that they do better than if you let the physicians actually do what the physicians do, which is argue over a transfusion trigger? Transfusion triggers have to go away. Patient blood management is just a stop on the road to getting to understanding the biologic complexity and understanding that that where we're at is to go to patient blood management. And I think I'm going to try to wrap this up because I'd rather take some questions here at the end than just keep going. I've always been a heretic. Heretics get burned at the stake. I've been burned at the stake more than a few times for me daring to say that, did we do it right? Did I do it right? Yeah, I transfused at 10 grams per deciliter for a large part of my career. I transfused at 7 grams per deciliter for a large part of my career, thinking that, gee, I was pretty good because I was one of the first guys to endorse that. But now I'm saying, wait a minute, that's not right either. Wait a minute, that's not right. What's right is to understand the complexity and say that a trigger doesn't exist. There is no such thing as a trigger, and we're all worshiping false gods that mean nothing. We're just repeating the same thing over and over again. Heretics attack institutions that are basically on shaky grounds, and then they suffer because they dared to tell the truth that they saw it different. Does the earth revolve around the sun, or does the sun revolve around the earth? Galileo paid a price for that. I pay a price for saying patient blood management is partially on the way, an evolutionary on the way to where you guys know it is, which is bloodless medicine. If the truth is trolled, sometimes the train goes off the tracks, and sometimes the train has to be rebuilt, or the tracks have to be rebuilt. And the understanding to get from point A to point B is so much more. So I'm going to conclude there and say blood is an absolutely complex organ. You saw I went by a lot of slides, which just merely proved it over and over to you, that blood is a complex organ. And I've had people say to me, well, Spiess, not every doctor can understand what you're talking about. Well, we have to, because that's how we live. And to simply throw our hands up in the air and say, well, I can't understand it because it's too complex. Why don't I just give up and not be a doctor to begin with? Why not say the truth is there somewhere, and we've been too simplistic, and we need to get more and more complex, and really embracing bloodless medicine as saying this is a vital organ system that we can't just throw away, and we can't just easily replace, and we can't argue about the triggers. And yes, we need to treat anemia, and yes, we need to be focused on patients, but we need to understand that there's nothing else that's as good as what flows in our blood to begin with. And I think I'll stop there and maybe take some questions. I can stick around for a little while, but I can't stay forever. I got multiple Zoom calls this morning. So I don't know, Kelly, how you want to structure this, but I want to just say thank you for giving me the chance to refocus my own mind and to look and say, philosophically, are we in the right place, even with patient blood management taking over the world to the point that it is? Thanks very much.
Wow, Dr. Spiess, thank you for such an excellent lecture. The visuals were fantastic. The information was above and beyond. And one of the things you emphasized the most was the need for education and understanding the complexity of blood. So we really appreciate your lecture, and talk about the definition of insanity. We'll get it right.
I can take you with my computer outside right now and show you where Einstein sat. It amazes me. And for that man to sit there and watch the sunrise and say, there's some grand scheme of energy. And here's what we're looking at. We're looking at blood, and we're arguing how many angels sit on the head of a pin. Stop it. Start arguing about, do we know enough to actually make the decision?
Yes.
No.
And like you said, education is key. So it looks like we are going to have some questions from our panelists, and we'll also have Dr. Blumberg and Dr. Freeman weigh in as well. But one of the questions that popped up was, do you feel that the current blood donor crisis due to the pandemic will move this category by default as a needed solution?
Absolutely. So I've written an editorial that I was asked to write for the journal Transfusion. And I was asked to write it when COVID came around. And my point in writing it was that just like we don't have an oil shortage, we have an overutilization. And that, once again, we need to look in the mirror. I find it fascinating that in 2016, the United States FDA and CDC and BARDA did a major computer study of what would happen if you had a major pandemic in the United States. What would happen to the blood supply versus what would happen to the blood supply if there was a thermonuclear terrorist explosion in downtown Los Angeles. Guess which was worse? The pandemic. By far worse. And it was modeled on the prior influenza epidemic that we had just come through. It was premonition of COVID, which was about to come. Now that study, that computer study, was filed by the RAND Corporation. It was reported to the United States Congress, and in usual United States Congress methodology, you know what we did? Nothing. We did absolutely nothing. And yet there was a prediction that we are going to have a massive shortfall of blood and critical blood when we get a pandemic. And because I dared to bring that up in the journal Transfusion, I was told this is just far too outspoken for us to be able to publish. I'm like, really? Isn't that the whole problem? So those things exist, and now we're right in the midst of it, and still people are arguing about what the transfusion trigger is, not go look in the mirror. Yeah, absolutely. Patient blood management. I just left the university and retired. I'm still an emeritus professor, but I tried to get them to be the best patient blood management center that I could make in the United States. And it was, well, it's just too costly. I don't know if we can do this. Let's wring our hands. So yeah, this is a constant uphill battle.
Yeah, and it gives way to your demonstration about shadow or truth. One of the other questions that was asked was, do you see a shift as far as major hospitals moving more towards having an open view with this patient blood management?
Yeah, I think, if we get to the point where 100% of American hospitals embrace patient blood management, then eventually we'll get to this next step. So, it has to happen, but it's happening slowly. But, I showed the train wreck going off the tracks. This train of patient blood management is gathering steam. But it's not there yet. So, we got to keep pushing on all the fronts. I'll try to keep thinking outside the box to say, okay, what if we actually did this and extended it to the full extent of what it could be? So,
yeah. So we wanted to see if there's any comments from our panelists, as well as Dr. Bloomberg or Dr. Freeman, to weigh in on this discussion. One of the other interesting statements that came up was the nursing population and how we could get early education as far as nursing at the bedside with that application. So Dr. Bloomberg, if you had a thought, we'd like to hear from you as well.
Sure, just briefly, wonderful talk, Bruce, as usual, thought-provoking and innovative and cutting edge. I've had a lot of time to think about some of these issues because in my own field of transfusion medicine, hematology, things you're talking about are truly heresy for obvious reasons. But I think your key point, which is that patient blood management is just one step on the way to some improved form of patient care, is absolutely quite correct. But I think we'll probably have to go through we didn't have a patient blood management program here until 7 years ago, despite the fact that I've been kind of pushing it for about 10 or 15 years. And the reason it happened was because administrators went to other meetings and heard other administrators talking about how it saved money. And that's true, because if you stop hurting patients, if you do better things for patients and they don't get quite as sick, it does save money.
So Toyota once learned that if you build a more reliable car, it will save you money. If you actually take care of the patient and take care of the patient first, you will save money. Why do we have to drag these administrators kicking and screaming to what all of us out in the woods? And Neil, you've been a heretic. You've been burned at the stake a million times, Neil. Why do we have to drag these administrators through that? And they can't see, they're seeing the horses, not the zebras.
I think we just have to accept the fact that change is very, very painful. And we have to be resilient. We have to not respond to craziness with craziness on our own. An example in the United States, the FDA has had 3 advisory committees vote almost unanimously in favor of universal leukoreduction reduction as one way of reducing the toxicity of transfusion. And politics has stopped it from happening. I think we have to approach this, in my case, because I'm a transfusion medicine doctor and run a blood transfusion service, reducing harm is part of this. And in addition to arguing for better practices, reducing the toxicity of transfusion or finding better ways of doing it is certainly part of that. But I think we have to recognize that us older folks, we're going to be like Moses in the Old Testament. We're going to show the way possibly to the promised land, but we're not going to get to live in it ourselves probably. This is going to be a multi-generational struggle. And I think if we understand that, and it's not that people have bad intentions, it's just that it's very hard to change and people are wedded to the way they've done things. And so as much as I'm not very good at it, I think we need to show compassion for our adversaries because they are trapped. They are trapped by the past, by indication.
Exactly what you said there, Neil, is people who say a transfusion trigger of 6 or 7 right now don't have bad intentions. They're trying to be as cutting edge as they possibly can, but they're led astray by all the evolutionary thinking before them that has led them down the line of saying, well, we need to just change the trigger rather than all the other complexity.
Well, and to be
talking because a lot of other people have questions or things they want to say.
Well, I'll just make one other point because I think, and you may or may not agree with this, I think transfusion still has a place in the care of patients until we can come up with a better solution to sanguinating hemorrhage or life-threatening anemia, which as a hematologist, that's why hematologists are so wed to transfusions, because our treatments cause life-threatening anemia if the disease doesn't. Until we come up with a better approach, we're probably going to continue to need to use this. And what I try to tell physicians is the hemoglobin trigger is not an indication for transfusion. It's an indication for when you might at least consider the possibility of transfusion. And you should only use it when it's a life-saving therapy, when you don't have any other alternatives.
So I agree with you 100%. And I stand on podiums around the world and say I've saved many lives by transfusion. But what I won't say is that I know all the time exactly what I did and why I did it. But it is so subtly nuanced. We need to understand the nuance rather than just be this blanket overlay.
So one of our panelists, Sarah, as well as Sherri, would like to ask a question or give a statement.
Just really wanted to, I appreciated the discussion about patient blood management. Doesn't start with blood utilization and in the blood bank, and it does require a multidisciplinary team effort. To establish these programs in the hospital systems, we really do need a multidisciplinary team and hands on deck. One person isn't going to do it. And also the discussion about blood being an ecosystem, and that if you're playing a role in patient blood management, no matter what your role is, you need to understand the entire ecosystem so that you can have these multi-collaborative discussions among the healthcare team.
I will also say that nurses can either make this work or they can torpedo it. And there are any number of wonderful patient blood management programs that get to the ICU, and when you get the buy-in of the nurses, they fly. And when you don't get the buy-in of the nurses, they don't fly. And so, the education, you can't educate 5 physicians and have them as your champions. It has to be a whole body, whole medical center, whole court press to educate everybody, to get like-minded. Why did it work, or why does it work at Englewood with Sherri and with Shander? Because they got a whole institution buy-in where everybody has a shared mental model. Why does it work with Nathaniel in Nigeria? Because people see the leadership and they buy in and they go, wow, this works.
Excellent point. So we'll take a question or statement from Sherri and then Dr. Ozawa as well.
Thank you, Bruce. Wonderful, as always. I guess I'm going to just comment and ask your perception a little bit. You and Neil already referred to it, and we've had many storied events, from Neil our storming the Capitol in New Jersey on this topic to Bruce us storming Washington together. Overall, I think that we have to really think about that next generation. And as Neil said, we probably won't live to see the promised land. But if we think about the sort of average age of the people involved, both in bloodless medicine and in PBM, I don't know, I probably shouldn't put a number on it, but it's not a very low number. So we've struggled with this as a group, kicking this around, I think, since SABM started, since we've had this conversation is, what can we do better with that next generation of nurses, of physicians, of other providers? Because, not to be blunt about it, but I think we're getting old in this field.
So Neil,
that next generation.
Neil and I just sat on a PhD thesis exam for Kevin Trentino out in Perth, Australia. There's a shining example of a next generation leader. And I see some young faces on here. I think Nathaniel looks incredibly young. I think Sarah looks incredibly young. There is a lot of youth and dedication to this. And I was just at the Society of Cardiovascular Anesthesiologists, and there are a lot of young people coming up who are really fascinated by it. It's time for some of us oldsters to not monopolize the podium all the time, and just hand it off to them and say, you guys run with it.
There's one interesting question, and I'd also get a little input from Dr. Ozawa. Will digital health, telemedicine, and patient engagement become the paradigm shift and the next direction as far as this category? So maybe you two can weigh in on that.
I think what will become the paradigm shift is when the lay public demands it. And Arie and Sherri and I, and certainly Shannon Farmer and others in Australia have talked about how do you engage the public into becoming as incensed as they were in the HIV crisis. And it's not to make the blood bankers feel defensive. It's to say that there's got to be a better way, and we, the lay public, demand it. So how do you engage them in it? Never let a good crisis go by without advancing. And the COVID crisis is a prime one. Why aren't we, on the front page of USA Today saying this could be solved? We don't need to cancel surgeries. This can be solved. We got the answer to that. But when Sherri and I and Steve Frank went to the United States Capitol to talk to congressmen about adopting patient blood management, they were really receptive until something happened, and that was called COVID. And then all of a sudden, nobody was interested in us anymore. Well, wait a minute. We can help you with that too.
Excellent. Okay, Dr. Ozawa.
Yeah, first of all, let me thank Bruce very much for this wonderful teaching that I got this morning, or it's afternoon where I am actually, but So I just want to weigh in on the issue of there are some patients that we just have to transfuse. To me, it's a catch-22 because we have an idea why blood transfusion doesn't work. In fact, we have agreed that it is ineffective. It doesn't have efficacy. And beyond that, that it is harmful. So we have an idea why. We know about the storage lesions. And I have learned a lot from the Society of Thoracic Surgeons and even Dr. Spiess on immunomodulation and Dr. Blomberg as well. So these things do not go away when the patient's hemoglobin is very low. They don't go away. The storage lesions are still there. The immunomodulation is still there. The adverse outcomes are still there. So that's why I said it's a catch-22. The patient that needs that transfusion is more likely to die of it because that's a critical patient. And the patient who could comfortably survive probably the transfusion does not need it. That is someone who is healthy. And I'm not really young, but let me presume, as Bruce said, that I'm young. So I could survive it. So
We lost your volume. Looks like you.
His connectivity, there we go.
can you hear me?
Now we
That
can.
was okay. That was, this issue was demonstrated in a patient we had that the hemoglobin was it went down to 1.3. So that would be a case that we would say, oh, this patient needs a transfusion. But I would say scientifically, that is a patient who doesn't need a transfusion. Because if we were to transfuse that woman here in Calabar, we'll be giving massive blood transfusion. And we know the problems of that. So she probably would not have survived, especially in our setting. And in any setting, it is challenging. The storage lesions are going to cause hypoxia. There will be more bleeding because a bleeding patient bleeds more, and the patient was bleeding, and so on and so forth. I could go on and on, disseminated intravascular coagulation and so on. But that patient survived with hemoglobin of 1.3 because she declined blood transfusion. And therefore, we used non-blood measures, which would not come with the problems of transfusion. So the point I'm making is that the worse the patient is, the more important it is to avoid blood transfusion. I don't know whether that makes sense.
Well, really want to thank everyone for such a robust discussion. Excellent presentation, great questions from the audience as well as the panelists. And our next portion is going to be the Bloodless Medicine and Surgery Programs, Improving Outcomes in Maternal and Child Health. And this will be a panelist discussion led by Sherri. So thank you guys all for your participation this morning. And a special thanks again to our keynote speaker, Dr. Spiess, for enlightening us and helping us think outside the box when it comes to the complexity of blood and the utilization of waste.
Uh-oh, someone's making noise. Thanks, Kelly. Okay, so, all right, that's better. Thank you. So thank you for the handoff, and thank you everyone for being here, all the attendees, all the panelists. Many people have been here every day for this very special week, and so happy that we're still here. So it's a really nice opportunity. Thank you, Nat, for the and the committee for the chance to be able to conduct this panel. We talk constantly about the fact that both bloodless medicine and surgery and patient blood management is patient-centered, but a lot of times we don't really get to hear the patient's voice as often as we'd like to. Today, for the next hour or so, we have okay. Now we know who it is. It's our pharmacist. Okay. We have the opportunity to hear from some of our colleagues who are involved in leading and managing bloodless medicine and surgery programs, as well as from some of our patients who had experiences and been through a lot, but are here to tell us the tale. And that's really a wonderful privilege. So we've got a number of people on our panel. And I think we'll introduce them as we go. to try to keep everybody sort of attached to who's speaking. So I think we will start. Let me make sure she's on. Robin, are you there? Let me see you, right? Okay. So we'll start with Robin, and I think most of these folks, again, have been in the field for a long time, but you can speak briefly about what you do and how your program is organized. Robin, you are a clinical navigator at the Cooperman-Barnabas Medical Center in Livingston, New Jersey. Of course, we spent a couple decades together at Englewood, together as colleagues. And so could you tell us in a couple of minutes what your bloodless medicine and surgery or transfusion-free program is like, how it's organized, and how you get your work done there in Livingston?
Yes, I will. I'll be very brief. It is so good to see you, Sherri, Yvette, and all the others that may remember me. Pleasure to see you. It's an honor to be a part of the Patient Blood Management and Bloodless Medicine Program. 21 years now. I did my clinical training at a level 2 trauma center that I worked for 15 years. And to be yanked out of that setting and environment into the bloodless world was just refreshing. Wonderful, wonderful to see how things could be done. So the transfusion-free, we know the nickname Bloodless Medicine and Surgery. We know that there is blood that will be shed in the OR. That happens, but transfusion-free is avoiding allogeneic blood. And autologous blood, not pre-donated, is something that can make a big difference, cell saver. We use that. So my role now at this new setting, new hospital, which is exciting, is almost 600 beds. It's the only burn unit in New Jersey. And so they can fly patients in as needed. They also do transplant surgery for kidneys and pancreas. So I'm a part of the Patient Blood Management and Bloodless Medicine and Surgery Program. I'm a part of the anemia clinic where we do IV infusions of iron, which has been wonderful, wonderful outcomes, avoiding blood transfusion becoming an issue. So I see that the planning, the implementing, and even evaluating afterwards to see what the outcome looked like. If there's a need to tweak anything, we do it to make any improvements. Our department, we have 2 directors, medical director and administrative director. We have 2 advanced practice nurses. We have a registered nurse that we work together in the anemia clinic. We have a coordinator for the office, and we just added on an ICU doctor who's really excited about embracing the program. And just one more thought that I found very exciting, you probably already know that now they found a way to reimburse for what I do, which is patient education. When I first saw that, I saw the list when I was doing my chart review of all the patients, and I saw that Jehovah's Witness was under a problem. So I ran to the director, Tanisha, a problem? We're a problem? She said, oh, don't get so excited. It's a good problem. It's a problem that can be addressed by your educating the patients so that our doctors can have the necessary tools in the OR. So now they finally found that it's worthy of reimbursement because it is a chunk of time, as Sherri knows. I've met even other nurses, fellow nurses, that didn't quite grasp all of the different options, the fractions, and so on and so forth. If you're not in this world, some of it seems foreign if you never had a real serious problem or a need for major surgery. So I think I covered all the bases.
Thank you. We'll have more time for discussion later. Thank you.
Okay.
Welcome. It's so fun to be together here on this panel today. And now we'll move on to another one of our colleagues from across the United States. On the other side, we have Joe Bishop with us from a program that's been around for many years and dear to my heart, but has changed names a few times, I think, as hospital systems have been absorbed and reabsorbed. But he's from the Virginia Mason Franciscan Health System, which is up in the Pacific Northwest of the United States, in the Tacoma, Washington, close to Seattle, which most people on the call have probably heard of. So Joe, would you make a couple comments about your bloodless medicine and surgery program and how that connects to improved clinical outcomes and why that is from your perspective?
Certainly. Thank you, Sherri. Our program has been in existence, serving transfusion-free patients for more than 23 years. And it's evolved from basically a one-person operation to about seven staff plus volunteers that work with the program. We do see a lot of our patients directly still, a lot of bedside care and so forth. Regarding the question of improved outcomes, I'd like to say certainly other types of programs are also able to achieve improved outcomes. Other programs that reduce blood transfusions are able to achieve improved outcomes. But a bloodless medicine and surgery program has several distinct advantages. Number one, it's patient-centered, of course. Patients are requesting this rather than it being kind of a top-down decision. Patients are asking for bloodless medicine. So being patient-centered improves, of course, clinical outcomes. Likewise, another advantage is it sets the highest bar. These patients will not accept blood transfusions. That's the highest bar, and that really challenges clinicians to really implement cutting-edge technology and be on the top of their game, and that certainly improves clinical outcomes. Likewise, as Dr. Spiess was mentioning earlier, it encourages interdisciplinary collaboration, and we know that that always tends toward improved outcomes. But I'd like to mention and focus on one more advantage of a bloodless medicine program, and that is that it is easily incorporated into the standard model for quality improvement. The structure of most bloodless programs inherently matches the design of the quality improvement model. And what does that look like? Well, an organization has an idea for improvement and a plan for change, first step. Second step, they test or pilot that change on a small scale. Third, they study the results and make any needed adjustments. And fourth, they implement the change in a wider and wider setting. So what does that model have to do with bloodless medicine and surgery programs? Well, imagine a healthcare system that wants to implement best practice by reducing blood transfusions across their entire organization. Who already has a plan for that? Who already is implementing it on a small scale? The bloodless medicine and surgery program. If an organization has a bloodless medicine and surgery program, those steps of planning and implementation are already in place. The bloodless program likely has decades of experience serving a small population, and it's already up to date on the latest evidence-based practices. So the template and the pilot program are already there. The interventions and protocols that are already resulting in better outcomes in the transfusion-free population can be progressively implemented in wider settings, bringing improved outcomes to more and more patients. And I'd like to say that that implementation in wider settings really becomes turbocharged when leadership, the C-suite, sees the value of reducing blood transfusions. And that's where the organization that I'm affiliated with is beginning to come on board. Our transfusion-free program serves 6 hospitals, but our parent organization is comprised of more than 140 hospitals, and they are now looking at implementing patient blood management across 140 hospitals, and they're looking at our transfusion-free program for policies, procedures, interventions that can be used not just on transfusion-free patients, but on all patients. So the benefits of bloodless medicine, the improved clinical outcomes is spreading to a larger population, and is taking place quite rapidly because now people at the top are seeing the value in it. So yes, I would say that a bloodless medicine and surgery program is the ideal setting to achieve improved clinical outcomes in bloodless care. I can't hear you, Sherri. Oh, there we
No,
go.
someone keeps muting me. Okay, sorry, I keep getting the message that I'm not allowed to unmute myself, so I better not mute myself. Okay, Joe, thank you so much. I mean, I really like the comments you made about fitting into the quality framework. I think that has been a little bit of a challenge, which I think we've adjusted to in the bloodless world over these years. This is, I think, 28 years for me in the space. And I think that when we first got started, we did speak a little bit of a different language. And I think that, you know, the bloodless programs for a long time were kind of off to the side in many hospitals, something that was really nice or respected, but didn't quite look or feel like, you know, the initiatives that hospitals were taking on. But I like your alignment with that to recognize quality processes, quality improvement processes. I'll make one other comment where I think that we now talk a lot about disparities, right? Both in medical and nursing education and in hospital settings. We talk a lot about population health. And really, to me, this bloodless medicine and surgery programs were the earliest model of addressing population health and disparities in a community and in a healthcare setting. So again, I think the more that we can speak the language of the institutions and the organizations with which we interact, the more and more recognized, I won't even say acceptable, recognize the importance of bloodless medicine and surgery will be to hospitals. But again, it's important again for us to, I think, understand where that fits so that our colleagues understand its value. So thank you for those excellent comments. Sarah, are you able to unmute yourself? I keep getting this message about being not allowed. Okay, it's working for you. Okay, let me close this message. Thank you. So we have with us as well, and we'll all have some time, Joe and Robin and others to comment later on. I think we'll have a little time. Sarah, you're a nurse administrator, my good friend and colleague on multiple projects now at the Patient Blood Management and Bloodless Care Program at ProMedica Health System. That's in Toledo, Ohio, here in the United States as well. So if you could help us a little bit, comment on the pillars of bloodless medicine and surgery and some of the associated techniques, and a little bit about how your program works there. And I think you're a more recent entry into the field of bloodless than some of us ancient fossils on the call. So any of your insights too are appreciated.
Yeah, so I entered the bloodless care realm in 2017. And at that time was charged to try to concentrate on expanding the program into patient blood management, which, you know, to our team is very much the same practice, just expanding it to everyone and giving everyone that better standard of care. So we expanded our team from a size of 2 nurses to a size of now we have 6 RN nurses and 1 advanced practice nurse, medical director who also is a hematologist, and we have a patient care coordinator who kind of manages the office, and that's working out really well for us. So our team manages both an inpatient and outpatient realm. We round on patients and we monitor their daily treatment plans. We monitor the condition of their health, their blood health, and take quick intervention and interdisciplinary communication with the different multi-collaborative people that we need to collaborate with so that we ensure that we are practicing bloodless medicine. And then also we have our telehealth anemia clinic where we do a lot of pre-op anemia and a lot of OB population. And so in the OB world, that makes up about 36% of our consults. And so last year we served approximately 500 prenatal visits. And really, the three pillars or standards of care, we start with the comprehensive anemia assessment, their blood health assessment. ProMedica practices doing a comprehensive blood panel workup at time of discovery that we have a pregnancy. So we do have early consults to our program, and we evaluate ferritin, current hemoglobin, CBC, iron, B12 folate. And this gives us the opportunity then to visit with the patient and really do a good historical assessment as well as current state assessment, and explain to them the goal, where we want them to be at time of delivery. And it has enabled us to be able to catch, you don't want surprises at time of delivery. And so we have been able to identify blood disparities that we did not know going in. So it's really great to have that plan and follow that pregnancy all throughout delivery. And we know that 60% of women who experience postpartum hemorrhage had no risk factor. It continues to be a health emergency that really a lot of the people who experience it had no risk factor going in. And so to have a prepared plan in place and to make sure that they go in with the best blood health possible is the number one thing that you can do. So the primary reason for anemia in pregnancy, we know, is iron deficiency. And that seems like an easy correct for us. We make sure that mom is taking oral iron in the first trimester. And by the time we get to the second trimester, if she's still struggling, we do move to intravenous iron because we want best benefits for both mother and baby. And so then we move on to the second phase. When it gets close to delivery, we want the minimization of unnecessary blood loss. And so our team and the OB team, we've taken a lot of time to develop those relationships so that they know everything we discovered through our blood health assessment before delivery. And so they know then whether to plan for cell salvage or any other thing that might cause additional bleeding. Postpartum hemorrhage remains common in obstetrics. In 2015, globally, 275,000 mothers lost their lives, and so it's still very significant. So the minimization of unnecessary blood loss really falls into the hands of the clinical team that we collaborate with, but things that they are prepared for is rapid response to a hemorrhage. The balloon catheter, if there's placenta abnormalities that they know of, is something that they use. Other things can be compression sutures. They pay close attention to uterine atony, all those reasons for the post-operative hemorrhage. And just really understanding what normal blood loss is and being able to measure it correctly is very important to our medical team. And then if there's anemia post-delivery, our team is brought back in to do what we do best, which is to make sure that mom goes home with all the building blocks that she needs. So we play the role of pillar number 3, which is harnessing and optimizing the patient's blood back to normal if possible. So postpartum anemia, 24 hours after delivery, if it's under 10, we consider that postpartum anemia. We want to make sure that she has what she needs before she goes home. It can at times be more iron. And then hemoglobin at 1 week, if it's under 11, we consider that anemic. if she's 1 week postpartum. And then 8 weeks after, she should be at a normal hemoglobin of above 12. And so we follow her until that 8-week checkup. We will run her lab scan and we can educate her about where she's at. So that's kind of our operation in a nutshell and as it relates to the OB sector.
Wonderful, Sarah. Thank you so much. Excellent work. And welcome to the field of bloodless. Even though it's been a few years. I know it feels long to you. Okay, so we'll more time for comments later. We'll move kind of segue into some of our patient stories as well, but we'll do that by starting with Sharon Sledge, who is there she is. So again, a very long time bloodless medicine and surgery and PBM friend and colleague. Currently is working at the Bloodless Medicine and Surgery Program here on the East Coast of the United States at NYU Langone Health in New York City. So Sharon, thank you for being here. And if you again could speak a little bit to your program, but also how, again, we're here and talking about maternal and child health. So how we apply some of these principles and techniques, particularly in maternal child health in your history and in your program there for safe obstetric care.
So thanks for having me as part of this panel today. So Dr. Spiess actually opened up his presentation by saying that the patient is at the center of the universe. And so certainly all of us on this call no doubt feel that the patient is certainly the center of bloodless medicine. And since we're talking about obstetrics, we would include the family in that as well. So how me and my team approach the patient, we work with them in a way that really promotes empowerment and supports their patient autonomy. And so actually that starts when I first reach out to the patient to set up our initial bloodless obstetrical consult. And one of the first questions I ask them is I ask them, do they have an advance directive, durable power of attorney, or a healthcare proxy? And I do that for two reasons. One, I want to really ascertain how serious they are, about bloodless. Do they really understand? And also, too, if they don't have a healthcare proxy or advance directive, I would like to encourage them to get one. Secondly, if they have one, I want to ensure that it's filled out correctly because I want to make sure that it meets the legal standards because that document is going to support them in their patient autonomy to get the bloodless care that they desire and are requesting. So then we move to schedule an appointment. We meet with the patient and many times their family spouse is part of that conversation. We have an extensive discussion reviewing minor blood fractions, medical procedures and treatments involving the use of their own blood. In other words, we sit down and really have a discussion with them about what blood conservation strategies may be appropriate for them and things that they agree upon. Those are then clearly documented. We have a bloodless medicine and surgery program treatment option checklist that's been uploaded into our electronic medical record, which we use Epic. And that's there for the whole team, for everyone to have access to that. Simultaneously, bloodless alerts are applied to that patient's record so that anyone who enters in and out of that patient's chart is aware that this is an obstetrical patient who declines the use of blood products in her maternal healthcare process. So I know this week we talked a lot about optimizing hematocrit and increasing the red blood cell mass. So we, like Sarah too, have a anemia screening process, protocol, and algorithm for our patients. So all of our pregnant women, and most definitely all of our bloodless patients, do have a CBC at the time that they come for their first prenatal visit. They're all placed on prenatal vitamins that contain iron. Those who have a hemoglobin of less than 11 have an evaluation for anemia, and that includes iron studies. And those who are diagnosed with iron deficiency anemia are also given some additional iron supplements. Routinely at like 24 to 28 weeks, those patients, if their hemoglobin is less than 11, their iron stores are reevaluated. And then if they have persistent hemoglobin levels below 10 by 32 to 34 weeks, despite our best efforts with oral supplementation, they are referred for IV iron. Again, now, when we meet a patient, perhaps if they're already on iron supplements, we may already just move to doing iron studies and referring them from iron infusions. And of course, our bloodless patients, those patients at 24 to 28 weeks, or regardless, have ferritin workups as part of their process. We know that nutrition plays a part of it, so our program, we can facilitate them being referred for nutritional consults to give them some guidance in terms of how their diet can supplement or improve their anemic status, or just to have a healthy pregnancy in general. And then in terms of minimizing blood loss, which again has been a major focus of bloodless medicine and what we do, being hemovigilant. So all of us on the team are always thinking about what can we do to minimize blood loss. So on our labor and delivery unit, we do quantified blood loss, EBL. So we heard a lot of talk about that this week, quantified blood loss. We know every drop counts, and we want to count for that. Postpartum hemorrhage, as we all have heard a lot about this week, can happen at any time. So we do have available a postpartum hemorrhage kit that's on our unit with all the associated medical therapies that we discussed at length this week. Minimal blood loss, blood draws again, is employed. And we actually have Cell Saver available on the unit. So we have our own in-house team, so that's available should that be needed. And then another thing that Dr. Spiess said today that, again, us who've been around for quite a while know that this is a team sport. So we do employ a multidisciplinary treatment team approach to blood conservation. So we start lining up all our consultants, maternal fetal medicine, hematology, anesthesiology. And as you'll see in the first patient experience that we have, many times when maternal fetal medicine is involved, our group of consultants and team players do grow exponentially. So together as a team, we formulate a plan of care for how we're going to avoid and control blood loss. So that's what we do.
Awesome, Sharon. Thank you. And thank you for all that you do for these patients and your diligent work over these many years at a number of institutions. So this is going to be a nice lead-in to our first patient experience. And we have a group here, including Sharon and Rosanna Aguilar is with us. And also we have the privilege of having with us Dr. Alkan, who is the Professor of Obstetrics and Gynecology and the Vice Chair and Division Director here again on the East Coast of the United States. And the Department of Obstetrics, Gynecology, and Women's Health, and the Division of Maternal Fetal Medicine and Surgery, so MFM as we call it for short. And he has a very special specialty as a real leader in the science of abnormal placentation, which is again a pretty rare find in terms of expertise. So a lot of experience and expertise, and very happy you could be with us here. He's from Hackensack University Medical Center and the Hackensack Meridian School of Medicine, again, here on the East Coast of the United States. So we're going to approach this as sort of a panel discussion. Thank you, Dr. Alkan, for being with us, and Rosanna and Sharon. Of course, you're part of the care of Rosanna as well. So we'll start with you, Rosanna, and to talk a little bit about your own situation. Again, the patients at the center, and you've been so kind to share your time with us. Can you tell us a little bit about what happened to you, your surgery, and how it ended up taking place, and the importance of bloodless in your care?
Thank you so much for having me. Yes, I sure can. So the bloodless surgery that I had was a bloodless cesarean section. In 2019, during my pregnancy with my son, Josiah, I developed a rare condition called placenta prurita, where my placenta attached itself to my bladder.
So, okay. And, I guess, Dr. Alkan, I'm sorry, I can't really see the view right now, but let me change the view so I can see you're here still. Yes, Dr. Alkan, could you make just a couple comments on how come that's a especially challenging situation in any circumstance, but particularly in a patient for whom transfusion is not an option?
Sure. Well, thank you for the introduction. And Rosanna, it's such a delight to see you. And that's what we do, right? To see patients live to be with their loved one, their children, family. So God bless. Obviously, the prevalence and the incidence of abnormally placental invasion is on the rise across the globe and in the United States. But once this invasion occurs, it leads to a major surgical catastrophe, which is bleeding. In fact, patients with true placenta perquita have a 30% chance, if not even 40% chance, of maternal mortality during the time of delivery. So clearly, this poses a huge risk for patients to undergo these surgical procedures.
Thank you. Thank you so much for that insight. We'll hear more about the situation as it transpired. So Rosanna, a little bit more from you, please. Tell us about sort of how you got, you approached seeking bloodless care for your situation, and also your reasons behind seeking that kind of care.
Well, due to my religious beliefs, I am a Jehovah's Witness, and I view blood as being sacred, as it represents life. So I take very serious the command in the Bible at Acts 15, 28 and 29, where it says to keep abstaining from blood. So when the discussion came up about my delivery actually needing surgery, I knew that the bloodless surgery was the only option that I had. So when, as far as the steps that I took for obtaining bloodless care, after my local doctor here notified me that he was scared to perform my surgery without the use of blood, we began to search. As previously mentioned in the program before, Jehovah's Witnesses have a group of volunteers and mature volunteers that work together with hospitals and doctors that are known as a hospital liaison committee. So they began to search, and several surrounding and major hospitals actually had denied my case as they were unequipped to handle my case without the use of blood. So the survival rate was, at the time they had told me, was only 2% chance without the use of blood. And they didn't want a mortality on their hands. So therefore, nobody wanted to take my case. And thankfully, the HLC had contacted Sharon Sledge, who was with Hackensack Hospital in New Jersey. And then, sorry, I get choked up. She did introduce me to Dr. Alkhan, who performed the surgery for me.
No, don't worry. We're so happy. We're so happy you're here and that things went well. And yes, I know how dedicated Sharon continues to be to making the right connections, and it's wonderful. So I guess for both of you, Rosanna, and for you, Dr. Alkhan, again, we said this is sort of a team sport, right? The patient's at the center, but it was a complicated case. Sharon, certainly for your comments as well. Tell us about how the case went, how you approached it clinically, and how things transpired. Please, Dr. Alkhan.
Oh, I'm sorry.
Oh, that's okay.
No, yeah. It's, as Rosanna chokes, it's also, I'm human. So I have the same feeling. If you just listen to what she had to say, she has her beliefs, and obviously we all have our beliefs and our philosophies, and sometimes our beliefs and philosophy may not be on the same page or the same line. But at the end of the day, if no one is going to provide the care to the patient, then that's patient abandonment. So someone has to do it. So as much as this preparation, what Sharon mentioned elegantly, and the rest of the people on the panel, how you prepare patients who are in bloodless medicine programs to optimize their hemoglobin hematocrit so that they could undergo surgery. So therefore, my job as a surgeon is to optimize my surgical procedure to decrease the blood loss. And that is my goal, my objective. Clearly, philosophies are different. Rosanna wants to live, but Rosanna doesn't want to get blood for her philosophical beliefs and reasons, which is respected. I, on the contrary, have the ethics of saving a life. And sometimes, you fight with this, right? Can I, as was mentioned earlier, can a human really live with a hemoglobin of 1? Can you really drive 100 miles more when your gas is telling you that there's only 10 miles left in it? Sometimes it's going to be an impossibility. So the question is, what do you do? So I think because of the complexity of Rosanna, we were able to put an enormous team together to ensure that she gets the best surgical care. Did I go through sleepless nights? Yes. Did I go through various strategies in my head? If plan A fails, we have plan B. If plan B fails, we have plan C, because the objective is there is no way a mother should die from childbirth. There's no way. And that was our goal. That was objective. And of course, medicine is collaborative. There is no I in the word team. And we all have to work with each other in order to optimize our outcomes. So yes, so Rosanna went through a very, very complicated, a very, very long surgical procedure. And I am so delighted that she did well.
Thank you. Thank you, Dr. Alkhan. And I mean, thank you so much for the eloquent way you described that. It's I think those of us who've been in bloodless for a while can speak, at least in the United States. Folks like you are challenging to find, to work with, and it's always sort of amazing to me that we don't have I think more engagement sometimes by our obstetric and gynecological colleagues. Sarah, you're nodding, and so we really appreciate you, but extra appreciate you, because there aren't many who really share that very balanced and compassionate view, I think, for patients in this circumstance. Sharon, please.
I'd like to thank Dr. Alkhan too, because he knows when he sees me knocking on his door and he sees my face, what do you want? And he has never, ever said no. And so we've had many, like you said, some sleepless nights, big team pulling together meetings, rehearsing, but at the end of the day, he was a great leader. He still is a great leader, and we're just pleased to have him as part of the team.
Thank you. So Rosanna, finish up the story for us. Tell us how things went, how the procedure went, and any comments that you'd like to share.
I appreciate the fact that it was a teamwork, because there was at least 30 in my OR that were all together. And going in, I appreciated Dr. Alkhan. He definitely, made that point known to everybody that I did not want to accept blood, and make sure that everybody was fully on board for that. And everybody agreed. So that was a huge team effort for them to be able to be all on the same page. He meticulously operated on me, and I was awake to be able to hear his commands. And it was just the most impressive, absolutely, delivery I could have had. As far as the surgery went, everything was obviously a miraculous experience. The surgery was a tremendous success. I'm still here today. My son Josiah is actually here as well. And he and I both, survived without any complications or compromising my beliefs by using other bloodless alternatives. We're living proof that challenging surgeries can be performed without the use of blood. And that was huge, because down here, it just did not feel that way. So I truly do have no regrets. I'm very appreciative to the HLC, who worked tireless on finding a doctor that had the confidence to take my case and who was going to honor my wishes. And I'm truly grateful and appreciative to the whole surgery team, and especially Dr. Alkhan, because he took on the challenge. He thought outside the box. He didn't look at me as just a number and a statistic rate. He did beat the odds. So without a doubt, I would definitely choose bloodless surgeries again. And the benefits were remarkable for me. They truly were. I was astonished to just find out that I had only lost 100 cc's of blood, and that was very impressive. I did end up, of course, using a cell saver machine, and there were other alternatives that were used as well. But to only lose 100 cc's of blood was a really remarkable benefit. The recovery time was less. My hemoglobin had increased immediately after delivery. And I honestly, I felt like I was a ticking time bomb. As Dr. Jones mentioned earlier in this program, if we deny and delay, it equals death. And that easily could have happened in my case if I didn't have a courageous doctor like Dr. Alkhan. So after being denied by 6 different hospitals down within this area, I truly believe, because of their inability to perform this complicated surgery without the use of blood. I truly believe that it's essential. It is essential for more educational instruction on blood conservation and alternatives everywhere. So I want to thank everybody for their hard work on this program. From me and Josiah, even though he's acting crazy. So thank you so much. We greatly do appreciate it from a patient standpoint, all the hard work and dedication that's put into this program. You're muted, Sherri. Sherri, you're muted.
Yeah, sorry, I keep getting muted. Thank you so much, Rosanna. Thank you, Josiah. We're so happy you joined us, and we're so glad you're with us and that things went well. Thank you so much to you, Sharon, for your work to the HLC, certainly, and Dr. Alkan for your dedication to Rosanna, and I know your patients before and since and more in the future to come.
Thank you both.
And thank you so much.
Thank you all. Thank you.
Everybody, Rosanna, congratulations. God bless.
Thank you.
So we'll move on to another very interesting patient story from down the road, one dear to my heart, from my home institution at Englewood Health. Not a mom in this case, it was a young patient, and I'm trying to look at my screen. Colin, there you are. Good to see you. You're wonderful. So this was, again, a different case. This was a case that I'll let mom, I think, tell us about, if you can, Dawn, a little bit, but we have with us a surgical team that took care of Colin, and an anesthesiologist as well. Dr. LaBelle, who you heard earlier in the week, is on with us, as well as Colin, who was our patient and looking great, and mom, Dawn Smoke, who is also with us. Your screen still says Colin, Dawn, but we know you're there. That's okay. No worries. No worries. So I guess we'll start. Dawn, I think you do such a wonderful job telling us certainly a little bit about Colin's history, your family history, and how things transpired as you came to Englewood. Okay, so while we're getting, Dawn, you're unmuted. Okay, there you go.
Well, I grew up knowing that there was a family history of severe hemophilia A. I had one brother who died as an infant just from bleeding after he ran, tripped, and bit his tongue. He bled to death over about 5-6 days. He then was followed. My mom had another daughter and then a son, again, who had hemophilia A. He and my youngest brother, who died in the 80s, both contracted HIV from blood products that they received to clot their blood whenever there was trauma or an injury. So they passed, and also my sister's youngest child also had hemophilia A and passed away, again, from contaminated blood products. When I had Colin, I had known that I was a carrier. He was my fourth child. I had 3 normal children and normal son, but he too, shortly after birth, they knew that he was a patient, also hemophilia. He did well for a long time. We did some recombinant clotting factor products, so there was no blood in that at all, and he did really well. Then when he was younger, as he grew, we noticed, the doctor noticed that he had scoliosis, which I had also, but his got to the point where it became a concern, and he started seeing an orthopedic specialist. And we were monitoring that, and he was up to a point then where he had to have a nighttime use of a brace from his armpits down over his hips to try to somewhat mitigate that curve. It apparently, but at the same time, he developed diabetes type 1. He lost a lot of weight, but at the time we were expecting a growth spurt, based on his age. So he appeared to be getting some correction of the curvature, just because the brace wasn't as hard to get on his body. But actually what was occurring is he was losing a lot of weight very quickly because of diabetes. When that was detected, we of course, spent some time getting that controlled, spent some time in the hospital for that. And then after that, we went and got him, went back to the orthopedic specialist, and he noticed the curve had increased drastically. So he sent us, recommended that we go to Shriners in Philadelphia, which they told us right up front that they normally do the procedure to straighten the curvature with blood, that was their routine. But anyway, we ended up, after some searches, again through a hospital liaison committee we used, because we are also Jehovah's Witnesses, they directed us to Englewood.
Thanks.
And go ahead, Sherri.
Great job, Dawn. Fantastic and awesome. And for any that are interested to hear more, there actually is a video. I think it's up on YouTube, right, Dawn, about Colin's story. But we can certainly share the link of a video that we did, sort of a little more documentary style, because we don't have enough time to tell the full story. But obviously a very complicated case with Colin from the orthopedic, neurologic, neurosurgery perspective, with the scoliosis, and of course hemophilia is obviously challenging under any circumstances, but particularly when there's a major surgery that we're facing. So I think with that, I'll turn it over to Dr. Steinberger, who is, again, an old friend and colleague, not old, I'll call longtime friend and colleague, working with our Bloodless Center in Englewood for decades on many challenging cases, and Greg too, Greg LaBelle, who is the chair and chief of anesthesiology and critical care at Englewood Health. And again, as we've said, as many people have said on this call, this is a team effort, and this was a challenging one. We probably don't have time to tell all the details, but I'll start with you, Abe, if you can comment a little bit on why this is challenging even without hemophilia.
Right, this is a challenging technical operation regardless of other issues, but when you add in hemophilia and insulin-dependent diabetes, it becomes super challenging. And actually, we should start with Greg, because I can't even begin to consider doing a case like this until anesthesia and hematology sorts it out. And they're like my lighthouse in the ocean. They'll guide me. Otherwise, I really can't do this. So they first had to really evaluate and sort out all the options. And once they really tuned everything up, it became a lot less difficult for me, because they did a lot of the legwork beforehand. So we should start with anesthesia, I think.
Thank you. As others have said on this, panel, it's all about teamwork. I came to Englewood 25 years ago and did not receive training in, patient blood management or anything like that. But, and I heard ads about it, and I always thought, what magic are they doing? And it's really not magic. It's a little extra work, and it's teamwork, and it's planning. And I think this was really a classic case of the planning. And as I pulled up the old chart, which was prior to us having electronic medical records, so I had to get the medical records to print it for me last week. But we went through a lot of, as Dr. Steinberger said, hematology, endocrinology, surgeons, nursing, post-op care, ICU, and the other item here that made it a little more complicated was the issue of the factor levels and needing to monitor them and administer them at the right dose, so that we didn't want to get too low. We also didn't want it to get too high. And our lab did not have that capacity to do that. So we had to make arrangements with an outside lab. We had to make arrangements with transport so that when we drew the lab, it got sent and we got the result back, within an hour or two, not 10, 12, 15 hours when, now what are you going to do? And then we had to make arrangements for a weekend because we needed to continue to do this post-operatively. So that was all kind of the pre-planning. Fortunately, that all went well, and you can never plan too much. So it went well. And then, we got to the surgical day, and everything really worked like a charm. The labs, we got results back, the monitoring of the diabetes, the intra-op use of coagulation testing from ROTEM to normal PT-PTT, monitoring the factor VIII levels, using Amicar, using Cell Saver, really using all the tools that we had available to us. And obviously the surgical team. One of the things with whether this is a patient for huge transfusions on an option or not, one of the keys to blood loss in this type of surgery is, moving things along. There is going to be oozing, there's going to be bleeding, and, the longer the procedure takes, the more that goes on. So, really having a plan surgically, which Dr. Steinberg could talk about, is critical. Get to the ICU, and then all the post-op care and the team there, did what they needed to do, as well as, again, continuing the blood management, and the testing and adjusting infusions and so on and so forth. But really, team effort. That's really what it comes down to. It's not that it couldn't have been done at any other institution, to be honest. In fact, many bigger institutions may have had the lab testing in-house or something, but we put a heck of a lot of effort into it. And Colin, it's great to see you. You look a little different. I haven't seen you in a while. So, great to see you and great to talk about this case.
Thank you. And so I guess we'll have Colin, as the star of the show, comment in just a moment and tell us more about his perspective. But Abe, just a couple comments on, I guess.
Right, I do. First of all, I don't know, because it's an older case, not on medical records, for people who want to see the curvature, it's very, very impressive. It was 78 degrees almost in the thoracic and 51 in the lumbar. That's a pretty impressive scoliosis and very difficult to fix. Post-operatively, much, much, much improved, but look at all that hardware. And it's not just hardware. In order to do this, you have to decompress certain areas of the spine. People think the spine is a bone, but it's very vascular. Bone bleeds. And sometimes in complex scoliosis cases, including this, we are prepared ahead of time to maybe not do it all in one sitting. We sometimes say, we'll stop halfway through if there's too much blood loss and come back. It's happened a few times. Here we lucked out. If I had to pick a case that we would have to two-stage, this would be it, but it went so well. The total blood loss after that entire big from T4 to L4, that's a gigantic surgery, we lost 800 cc's. I mean, that's not much in general, but certainly in a case like this. And we gave back, I think, at least 200 cc's. So he actually, he did great from A to Z. Every step of the way it was going so smoothly. We did more and more. And we looked and we said, hey, we're done. Everything went very well. I mean, anesthesia was on top of everything here. And he post-operatively, I haven't seen him in a while, which is always a good sign, because the ones that keep coming back are the ones that complain. And he's been fine. So very pleased. I see him now. He looks great. Correct.
Wonderful. Thank you, Abe.
I remember him walking around the ICU I forget what day it was, very quickly after the surgery. And that, you don't want to have patients in the ICU walking around.
Yeah, he's a tough guy. He's resilient.
All right. So Colin, thank you, Abe. Thank you, Greg. Colin, it's all about you. So we're so happy you're with us. You look fantastic. And it's been a couple of years, and you're growing up into a handsome young man. And we want to hear from your perspective a little bit, Colin, on how this all transpired now with a couple of years behind you to, I guess, look at how things went. Please tell us about your bloodless surgery experience.
Well, like Dr. Steinberg said, you don't really hear from patients again unless they complain. And it's kind of hard to complain when you experience what I experienced. When it comes to the surgery that was performed on me, it was pretty much anything but easy. Complex is definitely the word to use for it. With someone like me who bleeds a lot more than the average human, increased risk of infection from diabetes. And as a practicing Jehovah's Witness, I obviously don't accept blood transfusions. And all of these kind of makes for a dangerous trifecta of issues to deal with in a surgery, especially one as bloody as a spinal surgery is. But yeah, I mean, after the surgery, post-op, I was just laying in bed. I think it was day 2. I immediately started walking around the hospital again. And I was not expecting that from everything that I had known of what was going to happen during the surgery. Like when you have I want to say it was a 12-hour surgery, you don't expect to be up and around at day 2, especially when something like your spine is being worked on, which is just such a core part of your like movement abilities. But the things that were done and the strings that were pulled was pretty amazing to see in motion.
Thanks, Colin. We're so happy for your comments and that you're here. And Dawn, I guess Mom, Dawn, if you could kind of wrap up the comments. We've said already that bloodless surgery, medicine and surgery really is a team sport, and we're all in the team, family, patient, all of us clinicians. Could you make a couple comments on how you saw that in play, nursing and all these different folks working together?
Well, I'm a retired pediatric nurse. I've worked in several different areas of the hospitals. And I'd never experienced in any of those institutions the teamwork that went into getting everything ready to go. It was watching and listening and hearing about miracles, little miracles here and there. It was teamwork. Everything went down to just the most minute details. And we were astonished at the level of care that he got from weeks ahead of time, and everything just falling into place. And now hearing a few more details that we weren't aware of from Dr. Lobel and Dr. Steinberger. It's still miraculous to us that it happened, but at the same time, we have such faith in our God that he will bless the efforts that are made on behalf of us. And it was even afterwards when we feel honored to be able to share our story, because we felt, before we had any knowledge of what could be done, we felt that it was kind of hopeless, and it was one thing after another that was happening in his life, and the background, how I grew up, and the things that I saw, and then to see the total opposite of that past, with all of the, again, hematology and anesthesiology. I remember Dr. Lobel coming in and saying how he had to, on the fly, put together an infusion system for his factor because of the minute amount. He ended up using something from the NICU, an IV pump from the NICU. And that was amazing too. Those little things that just, constantly these people were thinking and making things better and fine tuning. And the care was great. He was walking the day after, and we went from walking around the ICU to walking around the hallway outside the ICU. And he just did well. Physical therapy, the whole ICU staff, the managers, the peds manager, everyone was involved. They were there. Some of them we didn't access, we didn't have to, but it was amazing, that network. And we really appreciate everything that you've all done for us.
Thank you. Thank you, Dawn, for the kind comments. Colin, one final comment. How's life now?
I'm here. I can stand. That's all I can really ask for.
All right. You look great. And again, huge thanks to Dr. Steinberger, Dr. Lobel, lots of people who aren't on this call too. We worked very hard and collaboratively. But again, Colin, with you at the center, and it shows that even these most challenging bloodless cases can be done when we all work together, put our heads together, and keep you in the middle. And we're so happy, Dawn, that you could be here, give our regards to David as well, the rest of your family, and Helen, so happy again. Thank you for being here.
Thank you.
And our final, not last but not least, interview is with our friend Elizabeth F. Young, who is from, I believe she's Nigerian as well, right, Nat? And she was an obstetric patient there at the University of Calabar Teaching Hospital in Calabar, Nigeria. Also taking care of that by a team of folks. And I think you are going to not speak to her case a little bit, but Elizabeth, thank you so much for being with us. I'm so happy that you're here. So could you tell us a little bit about the surgery that you had and how you decided that bloodless surgery was the right way for you to approach things?
Please, can you come again?
Could you tell us about what surgery you had, Elizabeth, and when, and why bloodless was important to you?
At a bloodless cesarean section, and this took place on the last month, 1st of April, 2022.
Very nice. And how did you obtain bloodless care? Why was this important to you, and how did you go about seeking that there in Calabar?
Yes, I first of all went for registration at the University of Calabar Teaching Hospital. When I got there, I met with a nurse who I requested I should be assigned to a doctor who will take care and respect my position as a witness without blood transfusion. And she considered my request and assigned me to Dr. Okon. When I met with Dr. Okon, I now tell him my stand concerning blood transfusion, and he accepted to treat me without blood transfusion. But at this very point of time, I never knew I had a case of placenta previa. It was later on when I did my first scan that the doctor now told me that I had a placenta previa type 4. And as such,
oh, I think Elizabeth froze.
Now
Okay.
educates me on how to go about my.
Okay, so Elizabeth, I think you have a little bit of a connection challenge. So while we sort that out, Nat, maybe you could, Dr. Usora, maybe you could weigh in and explain how, again, a placenta previa is a challenge in any circumstance, particularly in a patient from transfusion is not an option. How did we help manage Elizabeth in the days leading up to her surgery?
Thank you very much, Sherri. I'm not an obstetrician, but I work with obstetricians, and I was actually invited into this case because the patient requested bloodless surgery. So a former consult was sent to the bloodless surgery unit, which I am heading. And of course, we're informed that she had placenta previa type 4, meaning that her placenta was completely covering the cervix, such that, of course, it's impossible to have a delivery without cesarean section. And furthermore, she will be predisposed to bleeding, antepartum hemorrhage, even during her pregnancy. And even at cesarean section, she will be predisposed to postpartum hemorrhage because the uterus cannot contract very well, the part of it around the cervix. So it's a life-threatening situation if it's not properly addressed.
Thank you, Nat. And Elizabeth, it looks like your connection is back a little bit. So from your perspective, how did the surgery go? What was the outcome? What were the benefits that you perceived as choosing a bloodless surgery?
Surgery went well. It was successful, such that 4 days later, I and my baby were being discharged. And as at then, my hemoglobin level before the surgery was in 10 grams. But after that, as a last moment, I went for checkup, for postnatal checkup. My hemoglobin level rise from 10.1 to 14.1 grams. The doctors in the situation, they took the initiative to build up my blood level by giving me blood booster like transferon 12. And as such, even though I bled for 2 consecutive times, different times, the doctors were there. They cared for me by giving me tranexamic acid and vitamin K injection so as to control the bleeding. During the surgery, they were there with me in the theater. They give directives on how to administer tranexamic acid and vitamin K at different intervals so that they can control the bleeding throughout the surgery.
Wonderful. No, thank you, Elizabeth, for sharing that. And I think, and Nat, I'll turn it to you again to have a couple of comments. And again, I think my eyes very much opened when I came to Nigeria a couple of years ago to see how the work happens there. And certainly our perspective, it's not about transfusion, but our perspective on the importance of bloodless may be a little bit different depending on the resource setting and the state of actually the blood supply. Again, for bloodless patients, blood is never an option, but I think the situation with the blood supply, even in terms of infectious risk in certain parts of the world, heightens people's thinking even more as to the benefits of bloodless in general for patients. But could you make a couple comments on how we accomplish these things in lower, I think we all think we have low resources, but even lower resource settings, like perhaps for and Elizabeth.
Thank you very much, Sherri. Let me thank you again and commend you for coming to Nigeria in 2019 to share with us in our bloodless meeting at the time. It was a very great boost to our work because you are highly respected all over the world. So in a low resource setting, the very same principles that apply everywhere else also apply. The same 4 pillars as Dr. Shanda highlighted that we have in bloodless surgery, which is the 3 pillars of PBM plus 1 more. They all apply. It may be that we wouldn't have some of the high-tech stuff, but then again, the surgeries we do might not also be high-tech, but wherever the high-tech stuff is, high-tech surgery is being done in Nigeria, it's also possible to have the high-tech equipment. For instance, a certain way there's open heart surgery being done or transplants and so on. They can add a cell saver quite easily because it doesn't cost that much more than the rest of the equipment. But for, and of course, it would have been nice if we had such for Elizabeth, but clearly we didn't really need it because those high-tech stuff usually, for instance, cell savers, they are only cost effective if the loss of blood is more than 1,000 mils. And she definitely didn't lose more than 1,000 mils. So what I would like to highlight here are actually preventive measures. Elizabeth booked for antenatal care. That was very smart. And she booked early, I think it was like 2 months. Then the obstetric team, they respected patient autonomy. That is important. They didn't try to talk down the patient or force her to accept their own ideas. They immediately sent for the bloodless surgery unit. So that respect for patient autonomy and possibly having a dedicated unit like we have, because anywhere in the hospital, anybody has a challenge on bloodless care, they just write a consult to bloodless surgery. They raised her hemoglobin, which is the very first pillar. I think she went there with hemoglobin of maybe, I can't remember, it was like 12 or lower. But before surgery, it was 14 or 14 point something before surgery. And Elizabeth has mentioned how they gave her, how she was given tranexamic acid, vitamin K when she bled. So those who are not bloodless surgery practitioners may look down on those medications. But the fact is that those medications stopped the bleeding the same day. It wasn't like next day or anything. That same day, the bleeding stopped. She was only kept in hospital the second time to avoid something terrible happening at home. So she was kept at in hospital from 34 weeks to 37 weeks when the CS was done. having a multidisciplinary team is important. And fortunately enough, in this case, the surgeon, the anesthesiologist, and I think even the nurse are all members of the Bloodless Medicine and Surgery Group. The Bloodless Medicine and Surgery Group is multidisciplinary. It doesn't have anything to do with religious position. These are people from different religions, but they believe in the science of bloodless medicine and surgery. And they all put their heads together, and the bloodless surgery unit was invited. I was there with my house officer. So that multidisciplinary approach, as we have heard over and over again, is very important, team approach. The spinal and epidural was used, which is well known to be better in bloodless surgery rather than general anesthesia. Now, the timing of medication was important. I think that's what Elizabeth referred to. Of course, she was awake during surgery, and maybe she learned a bit of obstetric surgery and how to do surgeries. I hope she doesn't do them. So, but yeah, we had to direct on some of the timing. Apart from the medication that obstetricians give, like the oxytocin, which was given at the time of incision of the uterus, and again when the baby came out, and then agometrine after the placenta was out, and at the end of surgery, misoprostol. But we also have our own way of giving our tranexamic acid. We give it preemptively. We don't wait for the hemorrhage. So at induction, we already give 500 milligrams slow push. And then we add another 500 to the intravenous infusion. And we keep adding if necessary. We know that at 3 grams, we haven't exceeded. And of course, we ensured that vitamin K was given, which many would look down upon, but we use it and it works. Now, the post-op period, we avoided NSAIDs. In my setting, the obstetricians are very fond of giving a non-steroidal anti-inflammatory for pain relief. It works very well, but it increases hemorrhage. So for this case that is predisposed to hemorrhage already, we didn't allow that. We chose other things, opiates and other kinds of medication. And please, let me just share a picture here, so which Dr. Okon did not share. And I'm going to give you a quiz, Sherri. I'd like you, Sherri, I have permission of Elizabeth to share this. Sherri, which day post-op or which week post-op do you think this picture was taken on?
5
Sherri,
weeks.
that's 5 weeks. You missed it narrowly. It was on the 3rd day post-op, 3rd day.
That's fantastic.
So, and she was discharged the next day. That's the 4th day. So as Dr. Lobel said, it looks like magic or some out of the way thing. I agree it's a miracle because I believe someone created us to function in this way. But the fact is, once you follow the principles, the body takes care of itself. So when a patient is not transfused, the wound healing is faster. It's almost magical. And we don't know anything about wound infection. So she didn't have any wound infection, which reminds me of what Colin said about increased incidence of wound infection in diabetes. So that a diabetic patient is a patient not to transfuse, but I digress. So basically she didn't have any problem at all. And she got discharged, she and her baby. I think I've covered everything, Sherri.
Thank you, Nat. So any final words, Elizabeth? Thank you so much, Nat, for that. And thank you for allowing us to look at that image, Elizabeth. Anything you'd like to share with the audience in closing?
Yes, I would like to thank the Bloodless Surgery Unit who were there to support me throughout my stay in the hospital, as well as my doctor, Dr. A. Okon, who was very happy to see me. He always came around to check on me and check my blood level and to see how I was doing. I also think how you were there to support me during the hospital. With my greatest thanks to Jehovah God, who make it to be a success throughout the operation.
Thank you. Thank you so much, Elizabeth. Wonderful. Thank you for being here, Elizabeth, Colin and Rosanna, again, for sharing your stories and your families. We are so very happy that you're here. And thank you to all our fellow Bloodless Medicine and Surgery Program leaders, coordinators, old and young, mostly old, I think, no, but all of us who have continue in this with the patient at the center, trying to advocate for what's right. And so pleased and grateful that we have so many colleagues in many areas in the team sport, and that the science is further developing to help support the importance of bloodless medicine and surgery. So we have a number of questions, and again, we went close to the time, so I'm going to turn it back to you, Kelly, to finish up, and then that last few minutes that we have here. Thank you again, everyone.
So this was a really great discussion. One of the things that a question that came up was, how do you handle a situation when you have such complex patients without being sure of what the outcome is going to be? So we know that's almost a really hard question to answer.
Please, could you ask the question again? I'm sorry.
Given the complexity of the outcomes, how do you ensure with the team of how to plan ahead of time, not knowing what the outcome is going to be? Sarah?
I think okay, go ahead. Dr. Lovell had addressed that to some, or is it, Sarah, did you want to take that up? She's muted.
Just a brief comment. A lot of times my team does not know what the outcome is going to be. And we have to put faith and reassurance in the patient and their autonomy, and that at the end of the day, no matter what the outcome is, that we have honored that patient. And more times than not, we have a wonderful outcome. And it's really just about the planning, the discussions, and the collaboration, and knowing that you're doing the best and giving the best medical care. And, you know, sometimes when we get too focused on what is our outcome going to be, the stress level goes up, and then your productivity and your thought process and your creativity go down. And so we do a check-in as a team, and you know, think about that the outcome isn't our priority right now. We'll debrief later.
Yeah, I wanted to, I know we're going to be running short for time, but I wanted to give a special thanks to Dr. Ozawa and his planning committee. What an amazing group this week with the education piece. Also, Dr. Spiess really helped us to appreciate the complexity of blood as an ecosystem, as well as looking beyond the obvious. We had some great moderators. Thank you, Sherri, for excellent panelist discussion with Robin, Joe, Sharon, as well as Sarah, for providing an overview of their program and emphasizing the importance of teamwork. Also wanted to make sure that we mention the HLC and thinking about the advocacy that they provide for our patients. Excellent work with Dr. Edcon Steinberger and also Dr. Lobel for being top-notch physicians and meeting the challenges of our complex patients. But most importantly, how amazing was it to hear from these families, Rosanna and Elizabeth, for sharing your personal stories about welcoming the new ones to your family, and also Dawn and Colin. And I like Colin's idea of being able to walk. So it was just such a great panelist discussion, and really a good way to end our week. So just wanted to see if there's any other statements that our panelists wanted to share or anything else before we close. And we want to make sure that we're all in attendance tomorrow for the great quiz that we're going to take part in on Saturday's meeting as well. So if there's any other comments before we close, we welcome them. And again, what an awesome discussion, especially the personal stories. Like I'm always so enlightened and inspired to hear good outcomes with all the work that we do as bloodless medicine teams.
Hi, could I say a brief comment?
Sure.
I'll be really brief. I was 21 years participating with the Bloodless Medicine Program at more than one hospital. And I agree with Sarah's comment. My thought is always the strength of any program and even any bloodless surgery is the remaining calm. If the patient is calm, then I can be calm and I can think and everyone else can think. And so the skill, having your top docs involved in this kind of care, it greatly impacts the outcome. And the emotional support that clinical navigators, coordinators offer takes a chunk of time off the plate of the doctors and others involved in the care. That emotional support means a lot.
And I so agree with that, because every single panelist mentioned having the support and reassurance from the coordinators, as well as clinicians, recognizing that they're going to support their wishes was extremely important. And we even heard the doctors say that their goal is to save lives and they've lost sleep over it. So you can truly see the dedication amongst this team of people, and it does take collaborative effort. Anything else, Dr. Ozawa?
Thank you very much, Kelly. So I just wanted to add that if anybody's concern is outcomes, you want to have better outcomes, that is an important reason to do bloodless. If you're worried about the outcome of your patient, do bloodless, because science has told us that outcomes are better where you don't transfuse the patient. That's just what I wanted to add.
So thank you
And if I
all.
could add,
Oh, go ahead, Sharon. I'm so sorry.
if I could segue with what Dr. Ozawa said, and again about the outcomes. In over 15 years of doing this at various places, I can honestly say that I can count on one hand, and I've been racking my brain, about 3 patients have died over the course of 15 years. And I can tell you that none of those patients died because they didn't get blood. One person died metastatic CA that had nothing to do with blood whatsoever. Another person had severe head trauma, and the other person was a victim of COVID. So like Robin said, we keep it together. We may worry a little bit behind the scenes, but we carry that burden for the patients. But if we prepare carefully, I think this conference has demonstrated that it can be done and you can have tremendous outcomes.
I would add, we worry about lots of cases, whether they're, cases where transfusion is not an option or otherwise. I mean, it's all about planning, feeling comfortable with that plan, and trying to execute that plan. So, I appreciate that this adds one, I guess, little twist, but at the same time, the outcomes, this is why we're here today, because of the opportunity that was, I guess, kind of given to us to see how patients do without transfusion, right? And then we saw how well they do, and it's become more of the standard and should be even more widespread. So, as much as we worry about it, the outcomes are better. And, again, it's all about planning and feeling comfortable with our decision-making.
Excellent. Well, thank you all so much for your input. And tomorrow's session, Bloodless Medicine and Surgery, will be the quiz contest. So we hope you're all able to join. And that'll be led by Kevin Wright and Abigail Avara. So we look forward to seeing you all tomorrow. Excellent job, everyone. Take care.
Good job, Kelly. Thank you.
Bye-bye. Thank you.
Thank you, everyone. That was great.
Excellent.